This is the final topic of the EC 4000 Economic Foundations one module, which is part of the bridging program for the postgraduate diploma in health economics. The topic today is care as an economic good, and my name is Jane Bourke. What I will be, what I hope to do today is to bring together some of the concepts that you have studied to date in this module with myself and some of the other lecturers on the module, and I guess bring them together to talk about healthcare as an economic good, and I suppose decide to some extent or to debate or discuss whether healthcare can be considered an economic good. And is it similar to other economic goods, or does it differ in some way from other economic goods? So that's what we're going to talk about today. And if we were to talk about healthcare as an economic good, well, what questions would we need to consider? First of all, we would need to decide what is an economic good. And at this stage, sure, you know that it's a good or service that is scarce relative to our wants for it. Are the resources that are used to produce healthcare services finite? And has any healthcare system anywhere in the world achieved levels of spending sufficient to meet all of citizens' wants for healthcare? Okay, so some of the questions that we will consider. Underpinning economic analysis are two general observations. The first being that resources are limited, and the second that the potential uses of those resources are unbounded. Okay, and I think that's something that we're all too familiar with. Economic analysis is decisions and choices about the production and consumption of economic goods, goods which can be defined as rare relative to our wants for it. As we know, healthcare is not available in endless supply, and this is something that gains considerable coverage in the media in terms of people trying to access healthcare and not being available to them. And another thing that we need to consider when we consider healthcare as an economic good, the more healthcare we choose, the more of something else must be sacrificed. And this is something that you would have thought when you dealt with the concept of opportunity cost. So the inevitable trade-off in making these choices then is what opportunity cost actually captures. However, when we're dealing with healthcare, these choices are particularly difficult and emotive. Okay, so what we're going to look at now is an example of how we can use opportunity cost to consider different courses of action. So this example that we're going to look at is considering the opportunity cost of IVF treatment. Okay, so what we're considering is that that one treatment of, or if one patient received, for example, 3 courses of IVF for women less than 40 years of age, is an increase in the probability of a successful pregnancy by 0.3 or 30%. And is this good value for money? Okay, so if it is, for example, paid NHS service, is this good value for money for them? When you're answering a question like this, you have to weigh up the benefits against the opportunity cost. So the resources devoted to each IVF patient, for example, could provide one of these or could provide these other services. 1/3 of a cochlear implant, £2,700, would go towards 1/3 of a cochlear implant, 1 heart bypass operation, 11 cataract removal, or 50 vaccinations for MMR. Okay. However, when a government or a healthcare system such as the NHS is deciding between these options, there may also be other conditions to take into account, such as other sectors where this money could be spent, so not just in healthcare. Examples of these would be education, which is another area that people tend to have um, very strong opinions on, or very strong feelings on, towards in terms of where money should be spent and how it should be spent. Um, so, for example, was um, this money would um, provide half a junior school teaching assistant for a year, 2,000 school dinners, or in fact, it could be used in defence as well. Okay. So from a budget, the most efficient mix of services to fund will be that which generates the greatest aggregate benefit. Okay. So as economists, we are concerned with efficiency. So how should we use resources in an efficient manner that will ensure that greatest aggregate benefit? How also concerned with fairness or equity. And equity is considered the fairness in the distribution of healthcare and health outcomes. And it's also an important consideration in most healthcare systems. Okay, so from that example, and the example we were looking at there was healthcare. But in fact, maybe we need to take a step back and look at the idea or the concept of health as opposed to healthcare, actually, to get a greater understanding of how economics can be applied to health and healthcare. We can look at health, or we can consider health itself as a good, albeit with special characteristics. There's no denying some of the special characteristics. Okay, so we could consider health as a good, but we need to consider some of the special features of that good. And that it's scarce relative to people's wants. It's less tangible than conventional goods. Okay, so sickness or ill health or reduced health is something that's not particularly tangible. Okay, compared to if you were looking at more conventional goods like, say, apples and oranges. You can see reduction in the numbers of apples and oranges somebody has, but it's less easier and can be harder to quantify reductions in health. It cannot be traded because it is intrinsic to people. By that, I mean it cannot be transferred to others. So one person cannot transfer their good health to another in the same way that one person cannot transfer their ill health or bad health to another. So it's a little bit different in terms of that, and that impacts then on how we can consider it or how we can take an economic approach to it. Health as well as a good is affected by healthcare, but also by many other things. Okay, and those other things can be lifestyle factors, diet factors, etc. Okay, as I said, um, health is something to consider as a fundamental commodity with one key difference. It's not tradable. Okay, there are other differences such as um, uh, if that is returned to the previous slide, that it's less tangible, etc. But the key difference is, in fact, that it's not tradable. Improvements in health also cannot be purchased directly. So you cannot trade it from one person to another, but also you cannot purchase improvements in health as they cannot be purchased directly. To focus on the production of health, so the means by which individuals express their demand for it. So how people purchase different goods and services to ensure that they produce more healthy days. About purchase of healthcare or other goods. So we may demand healthcare or we may demand other goods, such as healthy food, gym membership, um, a new skills cycle to work with, something like that. Then that healthcare has a derived demand from the demand for health. Okay, so we don't really want to demand healthcare. We do want to demand good health or improved health. That's why we demand healthcare. So it's a derived demand. Consumption of healthcare then is undertaken simply to improve demand, um, or excuse me, simply to improve health. Okay. Okay. Economics. Two concepts are we distinguish between two concepts quite easily, and that is want or effective demand. A want is simply the desire to consume something, which we would all be familiar with. Effective demand is when this one can be backed up by willingness and ability to pay for it. Okay, and that's what we mean when we discuss effective demand in economic analysis. Okay, now, these concepts they can be easily applied to analysis of healthcare. However, there is one complication, and that is um, that people can state that what matters in healthcare is not actually want or effective demand. In fact, it's need. Okay, um, need is a concept that is quite difficult to define or to get a handle on. However, health economists generally um, consider need to be the capacity to benefit from healthcare. Um, and then, as you can see, not all wants or needs, and vice versa. Okay. Um, so you may benefit from going to see your dentist, but you may not desire to consume that. Okay, so it can be quite difficult to um, say that they are similar. In fact, they are not always similar. Wants and needs in terms of healthcare. The need for healthcare has implications then also for how we allocate healthcare resources. Okay, so we need to take account of needs in healthcare as opposed to just effective demand, which is something that we would see in the market for other goods and services, more so in terms of whether consumers can actually buy at the market equivalent price, whether they can buy the good or service at that price. Okay. Deciding who gets what in healthcare can be different to deciding who gets what in other markets, in that we allow the market to determine. So the equilibrium usually comes about from um, the demand curve and the supply curve intersecting, and that market equilibrium price is where the supply of goods at that price and the quantity demand of goods at that price meet. Economic concerns with what is produced, how it is produced, and for whom it is produced. And what we're going to look at here now are whether these issues are decided differently in healthcare. Okay, so we're going to look at a healthcare good in liposuction. We're going to look at two very different markets. So one will be a private market, so very similar to the markets we were looking at when we looked at the topic of market equilibrium. So very much a private market where price is dictated by what people are willing to pay and at what price the suppliers are willing to supply at. We'll also look at a public provision market, which is something we see quite a bit of in healthcare markets, in that the government intervenes and provides the goods um, to the market. Okay. Okay. So looking at looking at the market for liposuction, um, in a private market where you would allow market forces to determine who gets what. Um, so this is the example where we have a model of demand, which predicts how firms and consumers behave. And in some cases, it can be relevant to healthcare. So we're going to look at it now in terms of liposuction, where liposuction as a good would be bought and sold in a private market. Okay, so the same type of graph that we've been looking at before, price on this axis and quantity on this axis. In this case, the number of procedures per month. We have a supplier which tells us different prices of or the different quantities suppliers are willing to supply at different prices. And we have a downward sloping demand curve, so showing that as prices decrease, demand also decreases, demand increases. The market equilibrium here at this point where the two curves intersect, and this would be the price, and this would be the quantity, the market price and the market quantity. However, private markets like this, not everyone in the market who wants cosmetic surgery receives it. So those who obtain such services are who are both willing and able to pay for them. So these would be people on this side of the demand curve, okay, willing and able to pay at this price here. We cannot readily observe these effective demands. We do not observe wants that are not met because potential consumers are not either willing or able to turn them into effective demand. So this part of the market here, and we would consider this unobserved, unmet wants. Okay, so consumers may want to purchase liposuction, but are unable to do so at private market equilibrium price. Okay. In most markets, in most countries, and for most healthcare services and products, there is we do government intervention to a greater degree than in other economic goods. So we see regulation in terms of who may provide the service. We often see providers are told how much they are entitled to charge, what profits they can earn. We see subsidizing healthcare either partially or fully, and this may be funded via various types of taxes or social insurance, etc. In the NHS, as you're probably aware, the government dominates funding and provision of healthcare. So supply is essentially fixed in each time period by political decision. So a certain amount of money is dedicated to the supply of healthcare or the provision of healthcare. Moreover, healthcare is subsidized, so nothing is charged at the point of consumption. So effective demand is higher than it would be if patients had to pay. Figure here then, or this graph, shows an example of liposuction being supplied by the NHS. So the demand curve is the same in terms of a downward sloping demand curve. However, the supply curve is quite different to what we're used to. It's completely fixed, and that's the supply is fixed at this quantity here. So because there's no price system to reconcile demand exceeds supply. So in this case, demand is determined, who obtains health services is determined by factors other than price, what we saw in the previous example. And the reasons and the mechanisms that can be used and be used quite a lot in healthcare services then is waiting. Okay. So here, industrialization is being observed, met demand. Here they're observed but unmet demand. Okay, so we know how many people are waiting on waiting lists, but these demands are as of yet unmet. Okay, so it does not necessarily have anything to do with price controlling whether people can afford to pay for their wants, which would be effective demand. In fact, if that supply is at a fixed point. Okay. Two examples would be quite extreme cases. So the first one was a complete reliance on private markets, and the second, this one here, is a complete reliance on public provision. Um, in each case, not everyone wants to get the healthcare, or not everybody gets or the healthcare that they want. Healthcare is rationed. In the first example, the private market example, by price, and in this market here by some other mechanism, usually waging. However, in practice, most healthcare systems are a complex mix of private and public sector activities. Um, and so what I'm talking about next, why do governments get involved in healthcare? So what makes healthcare so different in terms of why governments don't just allow the market to determine who receives healthcare based on what they can afford? Okay, so is healthcare different? Okay, we've touched on a couple of ideas so far. Healthcare as a good or service is not demanded because it is pleasurable. It's demanded mainly to improve health, so it's derived demand, and it also affects other aspects of welfare. Healthcare is not available in endless supply. The more you choose, the more something else must be sacrificed. We refer to this idea in economics as the concept of opportunity cost. However, and I think most people, regardless of whether you work in the healthcare market or the healthcare system or not, you will be very well aware that these choices are particularly difficult and contentious. The first person who considered the question of whether healthcare is different to other economic goods and services, or whether the market for healthcare is different from the market for other economic goods and services, was Ken Arrow in 1963. Now, Arrow is a Nobel Prize-winning economist, but interestingly, his area isn't as economics and hasn't been really since he wrote this article in 1963. However, he is considered the person who created discipline. So he was the first person to write about it, and he asked actually to write about this area. It's one of the most widely cited articles in the field of health economics. And I guess the tenants that came out of this of Arrow's thoughts on the healthcare market, what principal feature of healthcare is uncertainty. And as you see there, it is the first word in the title of the article, so uncertainty. And what did I mean, or what did Kenneth Arrow mean when he spoke about uncertainty and healthcare? Well, he spoke how we do not know when we will become ill. We do not know if we will, and if we are ill, we don't know when that will happen. So there's considerable uncertainty around this idea of suffering ill health. We don't know when this will happen. We also don't know what healthcare will be required when we become ill, or at what cost. So there's uncertainty around health and healthcare. The demand for other goods tends to be regular and predictable. So we tend to have a pretty good idea of how often we will need other goods. For example, food. Ill health occurs randomly. However, its consequences can be severe. So recovery from illness then is as uncertain as its incidence. So not only do we not know when we will become ill, we don't know what type of healthcare service we will require or how much it will cost, but we also don't know what will be the outcome of that healthcare. That uncertainty can be on the side of patients and the physician. Okay, so as somebody purchasing or being provided with healthcare, you do not necessarily know the outcome of healthcare, but equally the physician may not know how long your recovery time will be, or whether you will completely recover from whatever illness you were suffering from. So consider certainty in this area. It really was the central tenet of our work. Um, our HILS tenet was that all of the special economic features of healthcare stem from uncertainty regarding both the incidence of disease and the efficacy of treatment. Um, and what he said in his article as well was that this uncertainty influences how consumers and suppliers behave. Okay, with the uncertainty consumers are faced with in terms of our patients being more influences how they behave, but also this uncertainty in the market or this uncertain relation to healthcare as a good is how suppliers of healthcare behave or how healthcare professionals or physicians behave. Okay, so just about that behavior a little bit, and I'm sure as you go through the postgraduate diploma in health economics, as you work your way through the program, you will hear about Kenneth Arrow quite a bit, and I know Brian will deal with how some of this uncertainty is picked up in the health insurance market. But just today, just to focus on some of the, I suppose, behaviour outcomes that Kenneth Arrow spoke about in his seminal paper. I'm just going to speak briefly about patient behaviour and how that can be impacted by the uncertainty and also provider behaviour. Looking at some of the key features of patient behaviour within the healthcare market. Okay, the things that makes healthcare different from other healthcare, or sorry, from other economic goods, is kind of test it as a product before consuming it. Okay, so it's not like a car that you can test drive or a dress that you can try on. Usually healthcare, you can't test it before you consume it. It's also assess quality even after experiencing it, okay, which is quite interesting. In that we can purchase healthcare, but as patients, consumers, it is very hard for us to assess the quality of that healthcare. And this is something I'm sure as healthcare professionals you've probably come back a lot, and that the way patients often assess the quality of the healthcare can be very based on the relationship with the doctor, perceptions around the care they've received. It's quite difficult to shop around. Okay, there may be just one provider of particular healthcare service that you need to purchase, and usually, I guess, when you're purchasing healthcare, you may not have time to shop around. You may not have the inclination to shop around, but it may also be that there are opportunities to shop around, and there may only be a very small number of providers. There may be very little difference in terms of the providers of the healthcare goods. We all know medical knowledge is complex, extremely so, and it can be difficult to obtain this information, but it can also be difficult to understand it. For that reason, we place considerable, as patients, we place considerable trust in the provider. Okay, so the thing that you go to, or the healthcare professionals that you go to, you expect them to provide you with full and complete information. Okay. There are also interdependencies between consumers' actions in healthcare. So the health-seeking behaviour of one consumer may affect the outcome or may affect the health of others. For example, obtaining a vaccination against an infectious disease can have an impact on the likelihood of others being infected. In a sense, I guess, this interdependency extends to individuals caring about the health of others. So in general, we would want people to obtain the health care they require. It wouldn't be something that people wouldn't want people to have access to, or others to have access to. Okay. However, on the provider side, doctors or healthcare professionals do not behave in the same way as other firms, I guess, or other professionals. Advice given by doctors is supposed to be completely divorced of self-interest. Um, so they're bound ethically to act in their patient's best interest. Treatment, therefore, should be dictated by clinical needs, not by financial interest. Okay. Now, this is an area that gains that has gotten considerable attention in the area of health economics. Or there have been numerous um, um, examinations of whether such a thing as supplier-induced demand exists. Okay, and that would be where a healthcare professional or a physician could induce demand so that they would gain financially from it. Um, and as with as with most things to do with healthcare, it tends to be quite an emotive um, um, issue or debate. So something to look forward to down the line, as in to discuss it, not to have to deal with it. We often see price discrimination in terms of providers or charging different fees to different income groups. Um, so sometimes doctors charge different fees to different people, as in they would charge fees to high income individuals, low fees to people with low income, and perhaps even not charge any fees to poor people. To the profession um, is just in terms of entry into um, the education side of it, to actually train to be a physician, but also there are very strict medical licensing regulations with impact on entry into the profession as well. Um, and find goals other than profit maximization dominate provision. So providers with goals other than profit maximization tend to dominate the provision of healthcare. So profit maximization is unlikely to be the sole or full motivation of providers, um, and social and ethical factors are likely to be important in determining their behavior as well. Okay. So as I said earlier, the central tenet of our work is that all of the special economic features of medical care, um, such as the ones I've spoken in terms of how patients and how providers behave, stem uncertainty, and this uncertainty relates to the incidence of disease and the efficacy of treatment. Entry to the medical profession is limited to those who have met certain medical training requirements. And this is because consumers cannot judge the quality for themselves and need to be protected, I guess, from unethical behaviour. Again, patients are poorly informed about what treatment is best for them. Trust is the key feature in the doctor-patient relationship. So a different relationship to some of the other relationships that exist on the market. If doctors are perceived to be behaving in, a profit motivated manner or commercially aggressive manner, this trust can break down quite quickly. So if somebody feels that a doctor is using them for financial gain, this trust can break down. These features, as I think you would agree, are interesting and can all be looked at in much more detail than we looked at here. One of the other things that is important to note is that Arrow, in his article, was careful, and he actually states this explicitly, that the characteristics are not unique to medical care markets. For example, other professional markets share some of these characteristics. However, when we take them together, actually suggest that healthcare is a very unique case. So the behaviors of consumers and providers of medical care are very different from the norm of a competitive market in standard economic theory. as you've probably gone through at this stage throughout the module. There are two main implications for as a result of the unique case of healthcare. So, for economic analysis of health and healthcare behaviours, by specialised theoretical approaches that acknowledge these differences. Um, and this is how, within healthcare economics and health economics, we have a very distinct theoretical and empirical research that you will be looking at throughout the course of the program. Um, it has developed in this way to help us improve our understanding of how healthcare markets work. Um, Secondly, a reliance on unregulated private markets for medical care is unlikely to produce outcomes that are socially optimal. Private market in terms of the markets that we would be familiar with and that we would have looked at when we looked at the topic of market equilibrium are when consumers are well informed and choose firms that deliver high quality goods, competitive prices. Um, in markets, and you probably come across the phrase caveat emptor, or let the buyer beware. That's not something that we would be happy to see in healthcare markets. And it's not a strategy that is acceptable in medical care, and that's why the roles of consumers and providers are very different, and the behaviour of each are often affected by the incentives created by third-party payments in the form of private or social insurance or by government intervention. All issues that you will be looking at throughout the program, and that I hope you enjoy throughout the program. So that's the conclusion of this particular topic and the conclusion of this module, Economic Foundations 1. I hope you've enjoyed it, and if you've any questions on anything that was covered during this topic or in my earlier topic, I'm more than happy to discuss it with you at some stage. Okay, thank you.